We will speak today about testicular tumors, part 3. Testis tumor in prepubertal boy. For testis cancer, a child is defined as prepubertal male. Compared to adult, testis tumor in children are more likely to be benign. More than 50% in children is benign tumor in the testis, but only 1% in the adult considered as benign. Usually, pure germ cell tumors in adult are usually mixed. So in adult, usually mixed, but in the children is usually germ cell tumor. Less likely to present with metastasis. Teratoma almost always behave in a benign fashions. Teratoma can have malignant behavior in adults. Seminoma is exceedingly rare in children, but it is common in adults. Most testis tumors in children are yolk sac tumors or teratoma. Embryonic carcinoma, karyocarcinoma, and seminoma are rare. Yolk sac tumor can secrete alpha-fetoprotein and or DHCG. Note that it is normal for infants less than 1 year to have elevated level of alpha-fetoprotein. Teratoma is almost always benign in prepubertal children. Treatment for non-seminoma in children, not pure teratoma. This tumor have malignant behavior, so we will look for treatment of stage 1A, stage 1B cancer, are treated with radical inguinal orchidectomy and surveillance. Stage 1S and 2 or 3 are treated with radical inguinal orchidectomy and chemotherapy. Okay, so 1A and P, this treated by inguinal orchidectomy, radical inguinal orchidectomy, and surveillance. But the stage 1S, 2, 3, this treated by radical inguinal orchidectomy plus chemotherapy. Pure teratoma in prepubertal boy, teratoma is almost always benign, usually present as stage 1A confined within the testis. Thus, testis sparing is option for this. Teratoma are treated with orchidectomy, radical or testis sparing, and surveillance. Granulosa cell tumor or benign stroma tumor are usually present in the newborn. 75% of this tumor present within 1 month of birth. Orchidectomy for granulosa cell tumor is curative. So 75% tumor present within 1 month of birth. If desired, a testicular prophysis might be placed after puberty. This is treatment of the germ cell tumor in prepubertal children. We have non-seminoma and seminoma. As you see here, seminoma, stage 1A or P, surveillance, orchidectomy or plus surveillance. Stage 1S, 2, 3 will do orchidectomy, inguinal orchidectomy plus chemotherapy. Seminoma rarely occur in children, best treatment is unknown. So this is the chemotherapy, is known as PEEP, that's bleomycin, etoposide, and cisplatin. It's known as PEEP. Let's speak about seminoma stage 1A and 1B, the management for this, surveillance, radiation, or chemotherapy. Surveillance is preferred management for most men with stage 1A or stage 1B pure seminoma who will be compliant with follow-up. So the patient able to compliant with follow-up, that is better to do for him surveillance if stage 1A or 1B pure seminoma. Radiation, the retroperitoneal nodes harbors occult cancer in less than 20% of men with a clinical stage N0, no adenopathy on CT. If all stage 1 men receive treatment, over 80% will be treated unnecessary. So if we manage all the patient with stage 1 without exclusion, we have up to or over 80% this might be treated unnecessary. The disadvantage of surveillance, these have high relapse rate than treatment. Strict compliance and intensive follow-up are required for the surveillance. Patients might have more psychological stress. You worry about high recurrence rate. Tumor size more than 4 centimeters and rate of the testis invasion might increase the risk of relapse, but the data are conflicting. Thus, the NCCN and AUA discourage using this characteristic to guide the treatment. So the size more than 4 centimeters and the tumor invade the rate of the testis, this increases risk of relapse. Relapse rate at the 5 years age is 15 to 20% for surveillance. For all stage 1 men undergo surveillance. So it's 15 to 20%. Relapse usually occur in the retroperitoneal lymph node. Most relapse occur within 2 years of orchidectomy, with less than 1% of the relapse occurring after 5 years. So treatment of relapse, restage and treat by radiation or chemotherapy. Abdominal external beam radiation, or known as XRT, rational occult metastases in retroperitoneal node are treated. So abdominal X-ray or external beam radiation require less invasive follow-up than surveillance. Remember, the radiation require less intensive follow-up. Disadvantage of external beam radiations, double the risk of the death from cardiac disease and double the risk of the secondary non-germ cell cancer. So the relapse rate at 5 years survival is 3 to 5%. Relapse usually occur outside retroperitoneum, outside the radiation field, primarily in the thorax, lung, mediastinal node, and supraclavicular node, or known as Verschuren nodes. When the iliac nodes are not radiated, the pelvic nodes are also common site of relapse. Treatment for relapse after radiation is chemotherapy. Chemotherapy, 1 or 2 cycles of carboplatin. Rational occult metastases will treat it and require less intensive follow-up than surveillance. So chemotherapy results in lower incidence of contralateral germ cell testis tumor compared to the radiation. Disadvantage of chemotherapy is myelosuppression, worse fertility, possible small risk of cardiovascular toxicity, and other long-term side effects of chemotherapy are not well defined. Relapse rate of 5 years survival of 5 years is 4 to 6% for 1 cycle, 2% for 2 cycles of carboplatin. Relapse usually occur in the retroperitoneal lymph nodes. Optimal treatment of relapse is unknown. This is the stage 1 seminoma, and this is surveillance. We're using surveillance, external beam radiation, and we have chemotherapy by carboplatin, 1 cycle or 2 cycles. The morbidity for stage 1 is very low in radiation and chemotherapy. The cancer-specific survival, 99% for seminoma stage 1 with surveillance, and 99% for external beam radiation, and 99% for chemotherapy, all is the same. The relapse rate at 5 years, 15 to 20%, 3 to 5%, 4 to 6% in 1 cycle, 2% in 2 cycles. Usual location of relapse, surveillance, the relapse in retroperitoneal nodes, and external beam radiation, relapse outside the retroperitoneum, and chemotherapy by carboplatin, it is retroperitoneal as well as surveillance. Okay. Treatment of relapse, surveillance, we will use external beam radiation or chemotherapy. External beam radiation relapse, we will treat it by chemotherapy. Chemotherapy by relapse is unknown, but we will use external beam radiation or chemotherapy. Here we have note that the relapse occur primarily in the thorax, mediastinal, supraclavicular node, lung. While iliac node not radiated, pelvic node are also common site for relapse. This point here. We will come to non-seminoma stage 1A or 2 or 1B, surveillance, radical lymph nodes, or chemotherapy. Surveillance is referred for a compliant man with stage 1A. Options for management of stage 1B include surveillance, chemotherapy, and radical retroperitoneal lymph nodes dissection. Surveillance rationale: the retroperitoneal nodes harbors occult cancer in 30% of the men with clinical stage N0, no adenopathy on CT. If all stage 1 patients receive treatment, 70% will be treated unnecessary by surveillance. Disadvantage of surveillance has a higher relapse rate than treatments. Stage compliance and intensive follow-up are required. Patient may have more psychological stress, worry about high recurrence rate. Risk factors for surveillance relapse include lymphovascular invasion (LVI), stage BT2 or higher, 50% of the tumor is embryonal cell carcinoma, absence of yolk sac tumors, proliferation rate more than 70% based on M1p stainings. Lymphovascular invasion is the most important factor for predicting occult metastasis in the retroperitoneal lymph nodes. Risk factor other than lymphovascular invasion probably do not contribute independent prognostic informations. Therefore, they are usually not used for clinical management. Relapse rate is 25% among all stage 1 men, 15 to 20% with lymphovascular invasion is absent, 50% with lymphovascular invasion is present. Most relapse, 60% occur in retroperitoneum. Most relapse occur within 2 years of orchidectomy, with less than 1% of the relapse occurring after 5 years. And treatment of relapse is chemotherapy for non-seminoma. Retroperitoneal lymph node dissection. That is surveillance. The surveillance management, as I mentioned, is chemotherapy. Retroperitoneal lymph node dissection rationale occult retroperitoneal metastases are treated. A less intensive follow-up is required. Compared with surveillance, as you see here, surveillance, that's strict intensive follow-up required. This is for surveillance at disadvantage, but in the retroperitoneal lymph node dissection is less intensive follow-up is required compared with surveillance. Disadvantage: it is invasive, has a risk of ejaculatory dysfunction, small long-term risk of bowel obstruction with transperitoneal retroperitoneal lymph node dissection. Relapse occur in 10% of men who with stage 1 N0. Relapse usually occur outside retroperitoneum. If retroperitoneal relapse are rare, treatment of relapse is chemotherapy. Chemotherapy for stage 1A or stage 1B. Stage 1A receive 1 cycle of polymyxin, etoposide, and cisplatin, is known as PIP, and stage 1B receive 1 to 2 cycle of polymyxins, etoposide, and cisplatin. Chemotherapy rationale: it is less invasive than radical retroperitoneal lymph node dissection. Occult metastases are treated even those outside the retroperitoneal. Relapse is lower than the other option. A less intensive follow-up is needed compared to surveillance and the chemotherapy disadvantage: it does not treat teratoma. It may cause infertility. There is a small risk of secondary malignancy with etoposide. There is small long-term risk of cardiovascular disease, many long-term effect of chemotherapy not well defined. Relapse rate is less than or equals 3%. Relapse usually occur in the retroperitoneum. Treatment of relapse, retroperitoneal lymph node dissection and or chemotherapy. Retroperitoneal relapse usually contain teratoma and should be treated with retroperitoneal lymph node dissection. This is the stage 1 non-seminoma, the management by surveillance, retroperitoneal lymph node dissection, and chemotherapy with bleomycin, etoposide, and cisplatin. Morbidity, all is low. Cancer survival, more than 98% or equal. Relapse rate for surveillance, 25%. Relapse rate for retroperitoneal is 10%. Relapse rate for chemotherapy is less than 3%. Usual location of relapse, retroperitoneal, as well as chemotherapy is also retroperitoneal, and radical retroperitoneal lymph node dissection is outside the retroperitoneal. The treatment of relapse for all, it is chemotherapy, but in the chemotherapy relapse, we will do retroperitoneal lymph node dissection and or chemotherapy. Relapse is 25% among all men. This is here, relapse for surveillance, and 10 to 15%, this 15 to 20%, this is when lymphovascular invasion is absent in BT1, and 50% when lymphovascular invasion in BT2. Okay, in men undergo surveillance after retroperitoneal lymph node dissection, the relapse is approximately 10% here. So for stage N0, 25% for stage N1, and 50% for N2, and more than 90% for N3. Okay, so for N0, the relapse is 10%, for N1 is 25%, for N2 is 50%, and for N3 is more than 90%. Relapse usually contain teratoma, therefore they often require surgical excision. We come to the abdominal external beam radiation therapy for pure seminoma. The external beam radiation treating pure seminoma stage, we have 1A and 1B and 2A or 2B. This is very effective in pure seminoma with this stage. So 1AB and 2AB. For stage 1, we'll use 20 gray appear to be as effective as 30 gray and seem to reduce acute toxicity. Thus, the recommended dose for stage 1A seminoma is 20 gray. This is the stage 1A or 1B. We'll use 20 gray, and we will use abdominal retroperitoneal node below the diaphragm, including epislateral iliac nodes as an optional. 2A 30 gray, abdominal retroperitoneal below diaphragm and epislateral iliac nodes. 2B is also, it is 36 with this the field of abdominal retroperitoneal node below diaphragm and epislateral iliac node. Here the epislateral iliac node is optional for 1A or 1P with 20 gray radiation dose. It is optional to do radiation for epislateral iliac node. But in 2A or 2B, it is not optional. You will do retroperitoneal lymph nodes radiation with epislateral iliac nodes. Include para-aortic nodes. This is the abdominal retroperitoneal nodes, including para-aortic node. Shielded contralateral testis, if it is not involved. The contralateral is not involved, we will shield it from radiation. Field that includes the epislateral iliac node are referred as dogleg field. For the men with scrotal violation undergo external beam radiation, when the epislateral iliac nodes are not radiated, 22% of the cases will recur in the pelvic node. Thus, the follow-up is in this men must be include pelvic imaging. So 2% of the cases will recur in the pelvic node. Toxicity from abdominal external beam radiation. We have acute toxicity, which is actually common and uncommon. The common side effect is nausea, and uncommon side effect vomiting, fatigue, and bone marrow suppression. And the late toxicity, rare cause of peptic ulcer. This is late toxicity is late cause of peptic ulcer, rare cause. And gastritis, secondary non-germ cell cancer like leukemia, and external beam radiation appear, as I mentioned previously, double the risk of death from cardiac disease and double the risk of secondary cancer. The kidney is radiosensitive and can be damaged when it is radiated. Consider surveillance for stage 1A or stage 1B and chemotherapy with EB 4 times for stage 2A or stage 2B. This is the chemotherapy ipsoid and bleomycin for this. In patient with periabdominal radiation, we will use surveillance and chemotherapy. Patient with inflammatory bowel disease and have testicular cancer, we will use surveillance for stage 1A or 2A and chemotherapy for stage 2A and 2B. Inflammatory bowel disease. Kidney in expected radiation field as a patient have adenopathy is the kidney or the pathology near to the kidney or show kidney, ectopic kidney. We will use this maneuver for stage 1A, stage 1B surveillance, stage 2A, stage 2B, we will use chemotherapy with IP 4 times or 4 cycles. Retroperitoneal lymph node dissection. Retroperitoneal lymph node dissection is surgical removal of the regular retroperitoneal lymph nodes, surgical technique, the remnant of the spermatic cord that is ipsilateral to the testis. Tumor should always be removed during retroperitoneal lymph nodes. For nerve sparing, the nerves are identified prospectively and preserved. Split and roll technique, lymph node tissue is spilled off the anterior surface of the greater vessels and then rolled off. Ligate the lumbar vessels and remove the lymphatic tissue in block. If necessary, the inferior mesenteric artery can be ligated when the marginal colonic artery is intact. Post-operative tachycardia is common and is caused by sympathetic discharge. Complication includes of lymph node dissection, ejaculatory dysfunction, child's ascites 2%, renal vascular injury 3%, and bowel obstruction 1 to 3%. Mortality rate from retroperitoneal lymph node dissection is approximately 0.3%. So this is the post-operative tachycardia is common and caused by sympathetic discharge. Complication, other complications, ejaculatory dysfunction, and child's 2%, child's ascites, renal vascular injury 3%, bowel obstruction, and the bowel obstruction is 1 to 3%. Mortality rate of retroperitoneal lymph node dissection approximately 0.3%. The morbidity is higher for post-chemotherapy retroperitoneal lymph node dissection than the primary retroperitoneal lymph node dissection. The mortality of post-chemotherapy is higher for seminoma than non-seminoma because the chemotherapy for seminoma induce a desmoplastic reaction that makes dissection difficult. So for seminoma, the non-seminoma, the morbidity is very high both chemotherapy, retroperitoneal lymph node dissection. One of the most important side effects for retroperitoneal lymph node dissection is impaired ejaculation. Impaired ejaculation after retroperitoneal lymph node dissection is caused by injury to the postganglionic sympathetic nerve T2 to L4, injury to the hypogastric plexus sympathetic nerve plexus near to the region of the inferior mesenteric artery. So injury to sympathetic nerve T2 to L4 or injury to hypogastric plexus, this sympathetic nerve plexus near to the origin of inferior mesenteric, and this is lead to sympathetic discharge. An injury to the nerve and the resulting ejaculatory dysfunction can be reduced by 2 techniques: modified retroperitoneal technique or nerve-sparing preservation technique. The best one, we will use the nerve-sparing preserve nerve, the nerve-sparing preserve nerve with the temple. This is 99% success rate. So the modified temple retroperitoneal is 70 to 90% of the cases have avoid the ejaculatory dysfunction. Avoid dissection of contralateral side, especially below the inferior enteric artery, and therefore it prevents injury to the contralateral nerve that's outside the temple. The modified temples without nerve sparing maintain ejaculation in 70 to 90% of the cases. Nerve sparing preserve nerve within the temples. Nerve sparing is indicated to preserve ejaculatory function. Nerve sparing can be performed with any temples even after chemotherapy if it is a not compromised tumor resection. Nerve sparing retroperitoneal lymph node dissection maintain ejaculatory function in 99% of the appropriately selected men without compromising the tumor removal. Modified retroperitoneal lymph node dissection template. Modified templates are an option for men with clinical stage 1 non-seminoma when there is no somatic type malignancy in the orchidoctomy specimen and when the intraoperative finding reveal no suspicions of retroperitoneal lymphadenopathy. If suspicion palpable lymph nodes are found with modified temples, then full bilateral temple should be performed. Modified temple decrease the risk of ejaculatory dysfunction by limiting dissection on the contralateral side below the inferior mesenteric artery. Modified temple have higher risk of pelvic and retroperitoneal relapse than a full bilateral temple. Thus, some experts recommend performing a nerve-sparing bilateral full temple in all men. Left side modified retroperitoneal temple are performed for left side testicular tumor. So we do left side modified temple for left side testicular tumor. A right side modified temple retroperitoneal lymph node dissection are performed for right side testicular tumor. For left, we will do left temples. For right, we will do right temples. The lymphatic metastases often spread from the right to the left retroperitoneum, but they usually do not spread from the left to right. As we speak previously, usually the lymphatic metastasis for testicular cancer from right to left because of cryptorchidism and undescended testes usually occur in the right side. So therefore, modified temples from the right side testis tumor typically extend further toward the contralateral side than modified temple from the left side tumor. This is various modified temple have been described by the AUA guideline 2019, right side modified temple, right common iliac, paracaval, pericaval, retrocaval, intracaval, intra-aortocaval, peri-aortic, and retro-aortic. All this must be removed as is clear in this. All this must be removed. Paracaval, pericaval, retrocaval, intra-aortocaval, peri-aortic, and retro-aortic. There was disagreement among the AUA panel as whether the para-aortic nodes above the inferior mesenteric artery must be removed. This is known as right side modified temple, is very clear in this diagram. Okay, we remove all these lymph nodes, and that's why it's called right side modified temple. This is the right side modified temple below the inferior mesenteric artery. Left side temples, we will remove left common iliac, as you see here, left common iliac, and para-aortic, and peri-aortic, and retro-aortic. All this will remove. There was disagreement among the AUA panels as to whether the intra-aortocaval nodes above the inferior mesenteric artery, above the inferior mesenteric artery must be removed. This is the left, the lymph nodes. There is a disagreement by AUA about removing above the inferior mesenteric artery. The example modified temple that are shown in this figure here include removals the para-aortic lymph nodes on the right side temples, intra-aortocaval nodes of the left side temple. The limit of the dissection for this example temple are superior limit renal vessels, inferior limit with a ipsilateral ureter cross the common iliac artery, and ipsilateral limit ipsilateral ureter. Contralateral limits inferior to the inferior mesenteric artery and aorta, and ipsilateral common iliac artery. Contralateral limit superior to the inferior mesenteric artery, contralateral ureter for the right side temples, vena cava for the left side temple. Surgical margin should not compromise to the maintain a temple to preserve ejaculation. And we see this is a bilateral. Bilateral will remove all the lymph nodes, drain the testis. This is the right side. This is the right side. We remove all the peri, para, and retro and inter-aortocaval plus right common iliac. Above the inferior mesenteric arteries, I mentioned that the AUA disagree with this. And this is the left. We remove all the lymph nodes as para, retro, and aorto and inter-aortic and common iliac, and the left common iliac. All this must be removed. This is the left. Okay. And this is for bilateral, we will remove all the lymph nodes. For bilateral, this is bilateral. Full bilateral temple indicate for clinical stage 2. Okay, but the modified temple right and left indicate for seminoma, non-seminoma stage 1. This is non-seminoma stage 2 or suspicious of intraoperative retroperitoneal node or both chemotherapy retroperitoneal lymph node dissection or somatic malignancy in the testicle. All this is for bilateral temples. This is the right modified temple and this is the left modified temple, all for stage 1 non-seminoma with no suspicion of intraoperative retroperitoneal lymph node and no somatic malignancy in the testicles. This is the lesion. This is the inferior mesenteric artery here, this level here. This is the two ureter as we described previously, like in contralateral side of each operation. For example, if we would like to remove the right side, we will find this here. Left side, you will find the ureter lie here. And in the right side, you will find the ureter lie here. For temples, the ipsilateral spermatic cord and gonadal vein should be resected, very important for all temples. For the temples should be extended, include no suspected of harboring cancer. Margin of resection should never be compared to maintain in the temple. The risk of teratoma in retroperitoneal with non-seminoma. Teratoma may be present in the retroperitoneal lymph node despite its absence in the orchidoctomy specimen. However, the risk of teratoma in the retroperitoneal node is higher when the teratoma was present in the testicles. This is non-seminoma orchidoctomy pathology, and this is the chance of teratoma in the retroperitoneal lymph nodes in adults. This is clinical stage 1 and this clinical stage 2A. If the pathology show that no teratoma in the pathology after orchidoctomy, the clinical stage 1 retroperitoneal lymph nodes in adult, the chance of this is 5 to 7% in stage 1 and 8% in stage 2. That in the absence of the lymph nodes might be found in the absence of the pathology. In the presence of the pathology, chance of teratoma in the retroperitoneal lymph node in adult is 2 to 19%, and in this is in stage 1, and in the clinical stage 2A is 33% for retroperitoneal lymph nodes in adults. Teratoma requires surgical excision because it's unnecessary, unresponsive to chemotherapy and radiation. It is better to do resection for teratoma. For clinical stage 2, predominance of teratoma in the orchidoctomy specimens support using retroperitoneal lymph node dissection instead of the chemotherapy because the teratoma in the testes increase the risk of teratoma in retroperitoneal. The rationale for resecting the nodes that have high likelihood of containing teratoma includes Teratoma is resistant to chemotherapy and radiation, but can be effectively treated by surgical excision. If teratoma is not removed, it can grow rapidly and in case or invade nearby structure is known as teratoma growth syndrome. We know that the teratoma have very slow progression, and therefore, if this happens is known as teratoma. If rapid growth happens, this is known as teratoma growth syndrome. If teratoma is not removed, it can be undergo malignant transformation in somatic malignancy such as sarcoma or adenocarcinoma. Untreated teratoma can lead to late recurrence of germ cell tumor. Thank you very much. This is the end of testicular tumors part 3, and we will meet again in part 4.